We can see, yeah.
Okay. So this is Nigeria. It's located at the western coast of Africa. The population of Nigeria is roughly 180 to 200 million people. And the city I live is also more than 4 million people. I don't have any conflict of interest to declare. This is how my journey started. In 2019, I went to Istanbul about the endoscopic spinal surgery, and I met with Dr. Tunç at Acıbadem Taksim Hospital in Istanbul. So he introduced me intensively to endoscopic spinal surgery. And from there now, I just started doing it. This is me. This is Dr. Tunç in his office, the time when I first visited him. And there was the OR. I went with Dr. Tunç in 2019 at Acıbadem Taksim Hospital. Then in 2016, myself and Dr. Hassan Kamil, we met in Tulum in Mexico, the World Federation of Spine Endoscopy. And then he got me the invitation. Thank you. So I'm here to my presentation. I just want to highlight the importance of endoscopic spine surgery in selected spinal pathology, especially those rare cases that to handle them, via open surgery can be a little bit difficult. And then the solution, easily and effectively can be handled using the scopes. This is what I am presenting. This is the scope. And then we are just talking about transforaminal and no any other, aspect of the endoscopic spine, not interlaminar, not UBE, but pure transforaminal techniques. We all know transforaminal technique, it was started by Anthony Young and Thomas Hoagland when they were doing inside out or outside in. Anthony Young, he popularized inside out, and then Thomas Hoagland, he popularized outside in. But transforaminal endoscopy has been evolving constantly, just like any other sciences and technology. So there are now even variations of transforaminal. In transforaminal, you can do transforaminal transiliac approach. You can do transforaminal transpedicular approach. You can do transforaminal tangential approach. You can do transforaminal far lateral approach. And also transforaminal just extra foraminal. You will not go into the foramen. You will be outside the foramen. And all these variations is just, it leads you direct to the target. Whatsoever is your pain generator, you just pursue it, you get it, and then you are done. So what are the targets? Just pain generators. That is what we are talking about. And then what transforaminal endoscopy is? Transforaminal endoscopy is a monoportal endoscope that has working channel, a single port scope with a single working channel, and then a single step incision to the skin of not more than 8 millimeter. That's what we use. And you use just your hands, your two hands. In some occasions, you might not even need an assistance. For example, in this picture, we can see this is the hand of my assistant. You can see he's just folding the hands, but watching the monitor. So this is what the endoscopy monoportal does. This is the working channel, this irrigation channel, and this is the lens. So all our working channel, we put our forceps, whatever we want. And we can see here, just a small step incision and finish. And this is my two hands, and then the pain generator is out. That's the disc. So this is the beauty of endoscopic transforaminal procedure. Then, of course, for successful transforaminal endoscopic surgeries, it's not just I see it, I'll go and start doing it. No, you have to have a good knowledge of clinical symptoms. Your patient, you have to evaluate them very well, and the knowledge of the surface anatomy of wherever the pain generator is coming from, then from where is it going to. And then the knowledge of radiographic anatomy is also very essential. The knowledge of cross-sectional anatomy is also very essential. Then, of course, it's not a surgery where you take it for granted. You have to be very strict, adhere to the procedural technique. And apart from that one, you have to have a 3D orientation of all this, what has been mentioned. Know your pen generator, you have the 3D orientation, and then I think you'll be good to go. So it is a procedure that has been constantly evolving now. We can see here, for example, this is transforaminal approach. I just did it in manicure, and then I made a little hole at the translaminar area, and we can see my ronger or my kerosene. I can see it. So even if the lesion is around here, I can easily, take it out. The anatomical perspective of the foramen is very, very important. We don't take it for granted. You have to know your foramen, you have to know the anatomy, you have to know every aspect of where you are going to. It's not a blind procedure. Transforaminal endoscopy is never been done blindly. It's done with knowledge, with your perspective on all the anatomy. And of course, this is a small video that I have shown the docking, considering the Cambian prism. So if you follow the rules the way it's supposed to be, surely you will get to your target. Now, this is the 3D, or I can say the sectional anatomy. If we look here, we can see in this picture here is extraforaminal disc, a very small disc, but sitting on the DRG and then compressing the DRG with a lot of pens. But if you take it here, this is the corresponding. And of course, this is the DRG, and then your disc is around here. So all your aim will be just to go directly to where your lesion is. Extraforaminal. And for example, if we see in this place, we can also see, this is a very rare, where you can see a foraminal disc, a little disc, and in this place also, it's a very small disc, foraminal fragment. So all this one can be successful, can be handled using transforaminal scoping with less destruction to the muscular structures. And of course, knowing your anatomy, knowing your zones is very vital. You have to know where you are going to, as I said it. Why transforaminal? The reason is transforaminal is very, very versatile. If you know how to do it, you can do a lot of things with transforaminal. I personally call it one scope, endless possibilities. So what is the concept? Why are we doing it? The whole concept is behind minimally invasive interventions. Wherever you have minimal intervention, the outcome for the patient is better, and then the pain and the hospital stay and bleeding, cosmetics, everything is better. And that's why the transforaminal or the minimally invasive comes in. That's why they brought the concept. For example, we can see this patient, he had open surgery, you can see here, and then, of course, still he was having his pen generator. How big it is? It's about 50 centimeters. And in open surgery, you open it big like this, and we use only a small fraction of the exposure to perform the actual surgery needed. If we see here, the exposure is so big, but the actual surgery, what is needed is just to remove this small fragment. And then, but endoscopy is opposite. It's a precise, tiny, focused exposure used to perform the entire surgery you need. Here we can see after this open surgery, and this is just our little exposure for the endoscopy to get to do our surgery successfully. So that is the concept. And then this hallmark of endoscopy spine surgery is just simplicity and results in surgical outcomes. And this one, it has been, postulated even in 1977 by Casper. We all know Casper. And Caspar, he postulated that efficiency of a surgical exposure equals to surgical target square versus the surgical exposure square. And this should be less than 1. So that is the concept of minimally invasive or endoscopic spinal surgery. It's just simplicity with a good outcome. Now, if we go back to this one, still we can see 50 centimeters, you cannot compare it with 0.9 centimeters. No way. So even for the patient, no muscle destruction, no tissue destruction, nothing. What is simplicity? It is a refined, straightforward, minimal approach that focuses on target. This is all our aim. So same operation can be performed with precise, focus, but limited exposure, where the surgeon uses almost the entire exposure to perform the needed operation. So we may consider B to represent the efficiency of an exposure in this slide. Therefore, if you consider efficiency of an exposure as a ratio of requisite anatomy needed to actually perform surgery relative to actual anatomy exposed, then transforaminal exposure are highly efficient. And this one, Louis Manuel Temialan, he has already said it in his book in 2020 and 2020. So now let's go in rare cases where we will see the efficiency of this exposure. We will talk about lumbar and then thoracic. Lumbar cases. Now, if we take this case, we can see this patient, he underwent traditional open surgery. We can see here the muscle damage. We can see even here the little collection after surgical collection, hematoma or infection or whatsoever we can see. But we can see around here where this white cycle is, still the pain generator is there. And we can see the surgical exposure being made. Then in this case, of course, it's a tubular case that, got infected. So transforaminal, in this case, is the universal standard for now. Because if you say you are going UBE, are you going UBE posteriorly through this infection where there are no even posterior structures? Or are you going through the very fresh wound that there are no posterior structures? But if you take transforamina, you will go directly and target this pain generator, and then the patient will be fine. So transforamina, of course, is very versatile in this case and is the option that is needed. Or in this case, if we take it, you can see this is L4, L5, and then somebody, went and put interbody cage with a hope probably of doing standalone decompression. And you can see the foramen of L3, L4 is very widely open. But the foramen of L5, L4, L5, you can see osteophyte around this area. This is a little magnification. You can see the foramen is compromised. So this osteophyte, by open, it will be very cumbersome for a surgeon to get into it. But using transforaminal endoscopy as a very rare case, we can see it here. So we can see it here. We are drilling it. We went transforaminally. We are drilling this osteophyte. We turn our bevel, we protected the neural structures, and then we are just drilling the osteophyte. This is the osteophyte. We drill it, and then up to this level, you can see the area being drilled, and we can see our neural structures. This is traversing nerve root, and this is the exiting nerve root. And then the patient became pain-free. So this is how good transforaminal endoscopy is. Or if we take this case, for example, this patient, he had surgery, he got his instrumentation, his implants, and what have you. And expandable interbody cage, but still he was having foraminal stenosis. We can see here with some early crest, and he was still in pain even after the surgery. He was not so happy. And what do we do? We went transforaminally. We reamed the SAP using manual reamer till we open up the foramen, and then we clean, we oblate the adhesions, and the patient now became pain-free. So we did foraminal stenosis, we did foraminoplasty, expandable interbody cage failure, and part of the cage also we drill it. Or if you take this patient also, he had instrumentations. We can see L4, L5. He got screws, but the surgeon who did it, he didn't realize that the patient problem was not needing instrumentation. His problem was hypertrophism of the SAP, as it is shown here. You can see how big the SAP is. So you can see here the CT scan, how big the SAP is. We went far lateral, we docked right on the SAP. You can see where our Tomshidi needle initially docked, where we put our guardware, and we can directly view our hypertrophied SAP. So actually, the game here is docking. If you dock accurately, yes, you will be okay. Here, this is where we have the nerve root. You can see the nerve root well compressed, and all this place is hypertrophism of the SAP, just like here. And this is after the shaving. When we shave the SAP, and this is the nerve root. After shaving it, becomes, free, and the patient is pain-free. Now, this is the process of shaving it. We use articulated bow, and we use diamond bow, number 3 millimeter, and we were drilling, not blindly. We were drilling, under articulated, because if you drill it blindly, you don't know what the other surgeon, did. So, but if it's under direct vision, you are certain you cannot injure the nerve root, you cannot injure the neural structures. So this is how we were drilling it using articulated bow, then we oblate it, and then after we can see our free nerve. And we didn't even remove the implants because the problem of the patient was not instability. The problem of the patient was not the implant. His problem was just pain generation. And then after it, he went with his implant, and he only came for follow. He was only coming for follow-up, and he never needed to tell us, "Oh, doctor, this implant is disturbing us. Let us remove it." No, he said, "I'm fine. I don't have any pain." So the implants, they can remain there. When I want to remove it, I can come. We say, "Okay, carry on." Or in this case, we can see this one also, he had multiple screw fixation, but his problem now is L5, L4, L5. And this L4, L5, here we can see the pain generator vividly. So the surgeon also, he fixed the implants, but he didn't realize that there was a pain generator, almost like paracentral and then foraminal disc that was compressing. We went far lateral, we went transiliac, like in this case. We can see the iliac crest very high, or not so high, but it's high. And this is our reamer. We rimmed through the iliac crest. We went directly to the foramen, and then we passed the foramen. We went to the almost central area, the central canal, and then we removed all the offending or the pain generator. And here we can see the nerve root clearly free. And also the patient, we told him, "Now you don't have pain." He said, "No, no pain." "What do you want? Do you want your implant removed?" He said, "No, let it stay. It's not going to disturb me." So the issue is not the instrumentation. The issue is pain. pain generator. Once you can target it, your patient will be happy with transforaminal endoscopy. And here we can see, the implant. And this is where we rimmed. And after 6 months, within 6 months, when we did our CT scan, we can see even the transiliac boring we did, it has almost healed completely, close. So that's the beauty of transforaminal endoscopy. In high iliac crest, you can still use your transforaminal endoscopy without any risk to the patient, mobility, or even life. Or in this case, we can see this one. This one we did it even yesterday. I included it in the presentation. As my friend used to say it, Dr. From Ukraine, he said operated in the galaxy, operated elsewhere. So, but the surgeon who did it, he didn't consider these factors. One, L2, L3, and L3, L4, we can see almost the posterior end place, they are kissing. And then the foramen here is also compromised, is tenos. And the disc space, we can see, is empty disc space. And then the implants, the doctor, put, we can see he didn't even put it completely. The doctor stopped at L3, like here, he stopped at L3, that is the AP, this is the lateral. He didn't complete it. So this side, there was, a feeling why the doctor didn't instrument this one and then extend the rod, even if he wants to do it. And then you can see couple, empty disc space, kissing end plate, foraminal stenosis, absent posterior structures like this one. He removed all the spinal processes and the lamina, nothing inside, and then inappropriate instrumentation. So of course, when you have this one, you know that you will have instability. And unstable back is a painful back. Nothing you can do about it. You have to stabilize it. So what we did, we went transforaminally, we rimmed, we did foraminoplasty, we went inside the disc space, we did end plate preparation endoscopically, just using 0.9 millimeter incision. Did end plate preparation, and then we inserted a cage. You can see it here. These are the markers of the cage. And from here now you can see the foramen has opened up. This kissing end plate is no longer there. The impingement in the nerve root is no longer there. Even if the patient moves, still, the back, the foramen will not be compromised. So this was our case in our cage inserter, and this is the cage that has been inserted. It was done yesterday, as I said it. You can see the date here, 10:05. I think around 12 in the midnight. That's when we finished the surgery. And then 24 hours, the patient is pain-free. You can see here, this is the compromised foramen, but now this is the open foramen. And this is the cage inserted. So what happens is this height restoration, indirect decompression, that is increase in foraminal window, a reduction of risk of screw breakage. Because if in this type of instrumentation, of course, you have a risk when the loading is, and then the end plate is empty. Of course, there is a huge risk of your implant failure. But with this one, at least the patient knows he can have his back for a long time. I just expanded it. I hope you see. You can see the foramen here. You can see the end plate kissing each other. But here, we can see it's well open and the patient is pain-free. We can see in this one, this is point A, where we inserted the cage, where we did the end plate preparation, all through this tiny incision. And of course, this was the adjacent level that we also took care of. And this is the place we took the bone graft to fill the cage. So you can see 1, 2, 3. But if you look at his previous surgery, from here up to here, more than probably 20 centimeters, that was the operation site for open surgery. So 24 hours, patient discharged home satisfactorily. Then, of course, Casper ratio or Casper theory played a very good role here. And or if you have down-migrated herniation, like in this case, is between L4 and L5, but the herniation is down almost subpedicular. You can also do it using your transforaminal, toolbox. Like in this case, you can see how we orient the vivell facing the lesion, and here we can see the fragment. And we removed it, and then the next morning, patient discharged home. And if you also have down-migrated disc herniation, like in this case, I presented it in an Arab Spine Society this year in Kingdom of Saudi Arabia. You can target, this is where our pen generator was, like here, the pen generator was here. You can see where it was here, just a little down migrated. You can angulate and go tangentially. When you go tangentially, you will meet your pen generator, and then you can remove it. So as I said always, docking is the rule number one, is the game. The iliac crest is here. We didn't remove the iliac crest here because our herniation, is down migrated, so we can just go tangentially and then remove our pen generator. Or in this, we can see the iliac crest is very big. This one, of course, went transiliac, and then we removed our pen generator. There was just a week after the surgery, and the patient, became pain-free. This was the patient, the one that I showed the high iliac crest. You can see the nerve structures. It was a very huge disc being removed. And we can see the annular. We can see free neural structures. And of course, this is our sleeve. And this is the herniated fragment bed where the hernia, was. This is how we did it, and patient became pain-free. This was, of course, the herniated fragment. We can see how big the herniated fragment was. So after removing it, patient became pain-free. And in some occasion, why do we need transforaminal endoscopy? We encounter some few cases, though not plenty, about 2 or 3 cases where we have congenital absence of the interlaminar window. So if you are doing UBE or you are doing only interlaminar, and when you come across this absence of interlaminar window, maybe you will not have any option but to go transforaminally. Here it is, the interlaminar window. We can see it should be equal according to anatomy, but in some rare cases, even here, we can see the interlaminar window between the left and right, they are not equal. But the one up is okay, but the below one is not equal. We can see here, we can see the interlaminar window here. It's around this area, is here. So always you should take note of the interlaminar window if you are doing interlaminar approach or UBE. And this is the one we got without interlaminar window. So we tried to dock and we couldn't get to where we are docking. We tried to bore and then we said, oh, we can convert into transforaminal. Sorry, yeah. And this is the patient. I also presented it in this Arab Spine Society. This is where we started, attempted interlaminar, and then we couldn't find the interlaminar window. And you can see how obese the patient is. So this is our point when we started, and then it failed. And then we saw there was no interlaminar window, and then we had to go transiliac, transforaminal, and then we removed this fragment. Here we are, you can see here, this is where we started, the interlaminar, and then we converted to transforaminal. So this is a conversion from one monoportal to another monoportal, from interlaminar to transforaminal. And it worked perfectly for our patients. Or in case if you have extraforaminal disc herniation, like in this one, we can see a extraforaminal disc herniation, we can see it here, and we can see here with excruciating pain that resists all the fragment and truly fertile. And any endoscopic surgeon who is practicing endoscopy, I will encourage him to also this herniation. This is the disc herniation, very massive one. But if you are not so careful, if you say want to go pure, far lateral, you might injure the intestine. So you have to take everything into consideration: the size of the patient, how big, how small, how the internal organs are. Or like in this case, we can see a patient very huge. Even this are Vivian. These are 150 or 140 centimeter or millimeter Vivian. It cannot reach. So we have to push. We have to push deep inside. So this is some of our challenges we are having. So maybe the industry will make a little longer sleeve. And then, of course, if you have a herniation that is up-migrated, we can see this herniation, up-migrated, subpedicular, blocking the way, the pathway. We can see it here. So in this case, we assess the interlaminar window, and we saw the interlaminar window wasn't that so big, and we went transpedicular, as is been seen here. We can see it here. We went transpedicular, and this is the post-surgery CT scan. This is the area we rimmed using manual rimmers, and this is our BVL that went directly transpedicular, and this is where we removed. And the next morning, patient became, somebody different, so happy. And now we go to thoracic also, how we can do it transforaminally. We know traditionally thoracic herniation is a big challenge to any person who is doing a spine surgery because no cord retraction can be tolerated by thoracic cord. Any small retraction, it will give you a feedback, negative feedback. Therefore, endoscopy now is a standard, gold standard. Initially, people we used to go transthoracic, whatsoever, very challenging. But now with our endoscopy, even a broad-based herniation, something like this, it can be handled. Yeah, we can see this one, another case also, calcified fragment, ligamentum flavum hypertrophy, canal stenosis, and myelopathy. So if you have your transforaminal scope or even interlaminar scope, you can go transforaminally and then remove this fragment that is causing the myelopathy. Also, we can see here, up-migrated fragment compressing the nerve. We can see also here, up-migrated compressing the nerve. And fragment removed. One thing with thoracic herniation is that you have to be very, very careful because even the docking can be a big challenge. You have to find accurate level. If you miss your level, all the surgery and the time you waste, it can be for nothing. And this is how we mark our levels. We can see using different needles. This needle is different from this needle. This one is different from this needle. So we know which needle is at which level. And then from there, now we start calculating, okay, yes, this is our target. This is our level. Once you get it, you dock on the AIP and the SAP. And once you dock, you make a little incision, and then you rim it. The rimming, I prefer to use bow than to use manual rimmer, because manual rimmer is like a blind procedure. But if you are using a bow, you are seeing exactly where you are going to. So the moment you are near the neural structures, you will be cautious enough. And not only that one, before we go into such surgeries, we take our model and we rehearse before going into the surgery. So it's not just about the incision, but how do you go? What decision do you take? This is how we dock. These are some shitty dock from the AIP to the SAP. We can see the lateral lateral exposure. And this is our Tomshidi, the rimas. Now you place your dilator, you calculate how many millimeters. This one is just for academic purpose, but already we are there. So we can see here just it's about 7 centimeters from the midpoint. 1, 2, 3, 4, 5, 6, 7. Yeah, this is 7.5. So that one is enough. And of course, our water irrigation, you maintain a very minimum water pressure because of the thoracic area. You can see here we are using the bow to rim under direct vision. We are drilling the AIP and SAP. Yeah, we can see here directly rimming it, drilling it till we reach. Yeah, so when we reach it, we can use our ligamentum flavum, which is calcified, and now we use a bendable hook to try to remove the fragment. And this one can also be done under local anesthesia. But since we have already crossed the learning curve, we try to, do all our surgeries under general anesthesia for our own comfort and for the patient's comfort. Yeah, this calcified part of the ligamentum flavum, you can see a little calcification. Let me go, and this is part of the fragment. This is the calcified ligamentum flavum. We are curating it, and beneath it, we can see the neural structures. So everything should be done gently, because this is a thoracic disc herniation. And then even the RF have to be gentle. Here we can see the neural structure. So gradually we are oblating it. And this is how, after the surgery, this is how from this to this. And this is just the incision. And of course, this is the patient, he came on wheelchair. He couldn't move for a few months, and now he can support himself. So this is the beauty of transforaminal. We can see it here. That is just before the surgery, 9 months after the surgery. A little myelopathy persists. Here you are. In some occasion where we have a broad base, we used to go, the two ways. We come from the left and from the right, and then we meet at the center, and then we free the nerve. All what we are trying to do is to avoid any compressing the nerve in thoracic area. Of course, after your surgery, this is the only little mark it will leave on the spine. No destruction, no muscle destruction, no bone destruction, nothing. And of course, we can see here. How much Yeah, we can see here, this is how we do the drilling of a calcified fragment, calcified ligamentum flavum, calcified anterior or posterior longitudinal ligament. Yeah, so we use articulated bow, and then we use our rongers, and then we clear the offensive materials. We can see here, for example, this was a calcified disc herniation. We can see the CT here also, calcified disc herniation. But unfortunately, like the surgeon missed his own level. And then he went and tried to do open surgery, and then he left the fragment up. So of course we have to use the method that we applied bilaterally. We came through here, and then we came through here. We met at the center, and then we remove it. Still a little fragment persists, but that one is not so much if you compare it with before the surgery. This is pre-op MRI, calcified D8, D9, thoracic herniation, you can see here. And this is the CT scan, and this is the MRI after decompression. And still, we can see why the surgeon tried to operate the initial stage. And in trying to do it, I think even he inflicted iatrogenic myelopathy. So this picture is of a patient who came with acute thoracic disc herniation, and immediately we did it. 72 hours after the surgery, you can see the patient watching his video, with surprise, because no incision, nothing. He was so happy. He left home. And as I said, this patient, the one I showed before, he came from wheelchair. Now he can at least walk, support himself, and he was incontinent. And now he has a self-control, and he was very sad. And later he became very happy. Yeah. So in conclusion, endospine surgery is being practiced now worldwide. Everywhere you go, you see it's trending. And it is very versatile. It's handling and fixing not only these herniations, but other structural lesions like the one I showed. Therefore, endospine surgery is not just good, it's a great concept that keeps fixing spotting patterns and a lot of gaps in spinal surgery, but endospine now is bringing out these gaps or any inefficiency, endospine surgery taking care of it. And then there are a lot of initiatives because of endospine surgery to improve the whole spinal lesions at various spinal anatomical regions. And in the absence of endospine, how do we handle such cases? Few lesions could be handled with difficulties. That's the reality. That's why even before people are saying, oh, this is a Feldbach. Oh, this is a Feldbach syndrome. This is a Feldbach syndrome. But in reality is to get to the lesions, even if you see it, it can be very cumbersome. So the option can be cumbersome to the patients and to the system. And what the endospine surgery is direct to target. You handle it, the patient will go home the next day or at least the following 2 days. He will be so happy. And hence, the endospine toolbox is no longer, a luxury. It is a must in the modern era. Every spine surgeon who wants to, get himself into a full spine, I think he should also have a knowledge and toolbox of endoscopic spine surgery because of some lesions that cannot be handled easily with other options. So it is not about incision now any longer. It's not about hospital stay. It is not about bleeding or post-operative pain management, but about clinical outcomes, especially in rare cases. I thank you all. Thank you.
Thank you so much, Dr. Ibrahim, for this excellent presentation. So we have some questions in the chat. I'd like to start by reading them.
Yeah.
But could you please stop sharing? Yeah. Could you please stop sharing your screen?
Ibrahim, can you please
stop sharing?
Can you turn off your presentation?
Stop?
Yeah, stop.
Yeah, stop sharing the
screen.
Okay, stopped, right? No longer?
No, we cannot still see the presentation.
Okay, I see it. Stop sharing.
Yes.
Yeah. Thank you so much. So moving on with the Q&A session, we have a few questions in the chat. So the first question is from Professor Suju. Where did you dock your thumb shitty and working cannula in this hypertrophic superior articular process case? Did you use your hand drills?
No. In the docking, I used Tom Shidi #1, the sharp one, for the docking. Then after the docking, when I saw my lesion, the structure, now I use diamond bow, 3 millimeter. So it's direct. It's not blind.
So
Because
the question is, where did you dock your Tom Shidi?
Pardon?
Where did you dock your Tom Shidi needle?
Right on the hypertrophied SAP.
On the tip or the base?
No, the tip.
The tip.
The tip, right on the tip.
And then you sent the working cannula without.
Then I sent that dilator. No, not really. I showed you the video. You can see a little nip I made. There was a little nip I made with the #1 Tom Shidi. And that was enough for me. Then now I use the dilator, and then I use the bevel, the tube, and I use the scope, wash it out.
You dock your Tom Shidi needle to the tip of the superior articular process, and then you send your guide wire.
Yes, I send my
inside
guide wire.
of the Tom Shidi.
Yes.
And then you send a small dilator, big dilator, and then working cannula.
Yes.
And you see the superior articular process directly.
Yes.
And then you use only high-speed drills.
High-speed drill.
Okay.
Drilling gradually. Yeah, because I know it's a hypertrophied SAP. I know the nerve root might be, compressed a little bit. So if I use manual drill, I might also, put pressure on it. And that's what we try to avoid because it's blind.
Yeah. In this case, the hypertrophic superior articular process is already touching the nerve root from the blow. And when you put the dilators and then when you put the working cannula, did the patient experience any pain or discomfort?
No, we did it under general anesthesia.
You did it under general anesthesia.
Yes.
Do you use general anesthesia always, or?
No, it's not always. We select the patients, and some patients, they said, no, we don't want. Let me sleep. Just do your job.
Okay.
So it's a patient preference and also surgeon's preference. When we started this transforaminal, initially, we were doing everything under local anesthesia. But when we got experience, now we select patients for general anesthesia. Mostly now, our 90% cases is under general anesthesia.
90% under general anesthesia. Okay.
90, yes. Yeah.
Okay. Doctor?
Okay. So the next question was, how can you take out the up-migrated disc fragments? And by up-migrated disc fragments, the question meant like not reach to the upper pedicle level.
Yeah, I said it. We have two ways of doing it. One, we can go transpedicular when we see the anatomical area. Two, we can go translaminar, not interlaminar, translaminar. And three, you can also go transforaminal if the up migration is not at L5S1. But if it is L5S1, because you cannot angulate, no, you cannot angulate. The earlier crest will be giving you some problem. So in that case, we go directly transpedicular, like the way I showed. We rim the pedicle a little bit, and then you see your herniation, and then you bring it out. Or if you don't want that one, you can go translaminar. You make a little laminar because this one we are talking about transforaminal. That's why I didn't bring the sample or example of translaminar.
Okay.
We have some of translaminar, yes.
Imagine there is a L4, L5 disc herniation, and there is a up migrated disc fragment, but not migrated to the L4 pedicle level, but it's maybe below the L4 exiting nerve root.
Yes.
In this case, how can you take out this fragment? It's below the caudal end of the pedicle, but it's up to the disc level.
Yes, like in zone 1, right? Or zone 2.
Yeah.
Yeah. Transforaminal, comfortable.
Transforaminal. Do you angled upward?
The only thing I do when I go straight transforaminal on the cambium triangle, my bevel will be facing, cranially, the bevel, cranially. So the tongue will be caudal. And when I reach that place, I manipulate it a little bit, and then I push it till I reach the middle of the canal. That is along the spinal processes. The tongue of my bevel will be at the spinal processes level. And when it reaches that area, I will now gently oblate. When I oblate gently, and then I will see my herniation and then bring it out. Finish. I don't turn the cannula anti-clockwise or even clockwise. The way I dock, this is how I stay. The bevel will look cranial. The tongue will face caudal. And if you maintain that position with gentle oblation, no rushing, gentle oblation, you put probably your RF at 3. And the moment you clear the soft tissue, you will see your herniation and you bring it out.
One more question, please. You showed us a case, down migrated case, and you put your working cannula down to the pedicle level, also behind. You reach the caudal edge of the pedicle with your working cannula. Is that right?
That's transpedicular. I went transpedicular. Yeah.
Oh, okay.
It's transpedicular, not pure transforaminal.
Okay.
I rim the pedicle.
Yeah. Okay. Thank you.
Okay. Moving on with the next comment. It is from Dr. Buhari Abdullah Sani. Thank you, Dr. Musa, for excellent presentation. Your delivery was clear, organized, and very informative. I particularly appreciated how you explained the key points with the confidence and simplicity. It was truly engaging and impactful. Well done. The next comment is, wow, what an excellent presentation. Certainly Nigeria can no longer be tagged third world anymore. With all these great things happening, it is indeed a great leap. Thanks to Dr. Musa and the team for the great works. Just a quick reminder, please also don't forget to write down your name and institution while commenting and asking questions or giving remarks. Moving on with the next comment, I guess. Dr. Musa, I really appreciated your effort. I've once been your patient in January 2026, Prime Specialist Hospital, Kana. I underwent this decompression surgery and I'm doing fine now. Thanks by Kuburi Ahmed Gusau. And finally, we have a few more thank yous by thank you to Dr. Musa. Well done, Chief. Great presentation by Abu Bakr, Musa, Muhammad, and Abiola, Dr. Abiola, I guess. I'm sorry if I'm butchering the names. And the next one is from Azmi Manshawi. They are also thanking you for the great presentation, and they appreciate your effort. I see we have a lot of thanks and appreciation in the chat, which is great. And I'm also thankful for the presentation. If we have, oh, we have another thank you as well from Dr. Ibrahim Muhtar. I think it is now time to do we have Dr. Krozek online in the chat?
No,
If he
I
would
think
like to.
he has left.
Yeah,
He was here, but he has left.
yeah. So I don't think we have any other faculty members to give the floor. Okay, I get it. Okay, I think there are no further questions or thank yous in the chat. It was endless, honestly. With that being said, that means we will be drawing tonight's session to a close. Dr. Ibrahim, on behalf of everyone here, thank you once again for your time, your expertise, and this great discussion. Thank you to the audience for their active participation. And I will now be handing the floor back to Professor Suju for the closing remarks.
I want to thank Dr. Musa Ibrahim for this great presentation. And lastly, I want him to explain briefly this thoracic case is very impressive, actually. I want you to tell us last time where did you dock exactly and how far from midline? Did you dock the Tom Sheedy to the superior articular process, inferior articular process in this case? And how far did you choose the entry point from midline?
Yeah, thank you. The entry point from the midline is between 7 to 8 centimeters from the midline. And once you get to 7 to 8 centimeters from the midline, I didn't dock inside the foramen. I didn't dock on the SAP. I dock on the AIP, that's the inferior articular process. That's where I dock. And when I dock there, I try to bow it with a power bow, not with manual reamer. As I said, manual reamer in thoracic is a blind process. For me, that's my opinion, it's more dangerous because you are not seeing what you are boring. But if you get a power bow, as you are boring, you are seeing what you are seeing, and then you go directly to the SAP. And the moment you get to the SAP, you also bow it gradually. You bow it. You bow the SAP, not totally, part of it. When you bow it, now you see your ligamentum flavum. And the moment you see your ligamentum flavum, you curate it a little bit. You use your hook to bring it out a little bit. And then you use your RF to oblate it a little bit till when you see your neural structures. And when you see your neural structures, from there now, you define your level. Are you going up or are you going down? If you are going up, you turn your bevel to face up. That is cranium. If you are going caudal, you turn your bevel, it will face the caudal aspect of it. And at no moment you should exert pressure onto the spinal cord at no any given time. That's why I use bow. If it is calcified, when you are using your bow, you feel everything goes through your body. And you keep drilling, calcified, you see the dust. The calcified dust will be coming out and then you'll be seeing your way. You have to be patient. There's nothing to rush in such case because it's thoracic. It doesn't forgive.
Yeah.
And water pressure also, you put it to the minimum that you will see what you are doing. Don't say, oh, put high pressure. No. If it is only 10, that can give you a clear view, let it be 10. If it is 5, can give you a clear view, let it be 5. Don't say, I will take it to 100. No, because already the canal is small. You put more pressure, you are going to compress the spinal cord. And this is what I do.
Thank you so much. And I think there is 2 more. Thanks, Muhterem.
So the next one was from okay. It is from Ibrahim Lekan Jibril. So more power to your surgical MII hands, our enviable MD. Team PSC Canada is proud of you always. Very sweet.
Thank you.
Okay. Also, I want to thank everyone who joined us today, this evening. Okay. I hope to see you again, Musa
We'll see
Ibrahim.
again. Yeah, we'll see again.
Yeah.
Thank you.
Thank
Have
you
a
so
lovely
much.
night. Thank you.
Good night.
Good
Good
night.
night.
I am closing the session right now. Goodbye.